Welcome, and thank you for joining the third Ask the Expert COVID-19 virtual town hall. My name is Tom Piechota. I'm the Vice President for Research, and I'll be your moderator for this town hall. We've heard a lot about what's going on with coronavirus, and we're here to update you all on some of the facts and figures, hear from some great experts today. In waiting to get started here, I was having some great conversation with the experts, so I think you're going to hear a lot of really good things. We're at a really interesting time since our town hall has started 21 days ago. We've experienced a 9 times growth in our cases here in California. On March 26th, when we had our first town hall, we had 3,000 cases in California, which was a lot. As of today, April 16th, we have 27,000 cases. So certainly has grown a lot, but I think hopefully we all see improvements. Everyone's doing their part, staying home, and we hope things are working. I think you're going to hear some really interesting things from experts. Chapman's doing some interesting things also as a community. I think one of the really enlightening things that I heard, you're not going to hear it from our panel today, but really one of the great things I heard from yesterday was from our Thompson Policy Institute. They do a lot of great things with teacher education, and they adjusted their teacher education and offered it virtually to over 100 participants in this past couple of weeks through webinars, and all of this was work supported by the Gates Foundation. So it's just really great work, and it demonstrates how everyone's really adjusting to what they're doing, helping the community, and really offering kind of great work that's meaningful. I'll be introducing our speakers. They represent a broad range of expertise, whether that's in economics, physician's assistants, science and technology, anthropology, and that really represents how the coronavirus COVID-19 touches many parts of our society. Just some logistics on the town hall. You'll see on the right-hand side there's a Q&A box. We really want you to participate in this and post questions that we will take and give to the presenters. After about 30 minutes, we'll have a lot of time to present them questions and have them give responses to those. And so you can start presenting those now if you want, while they're giving their presentations. So with that, let's go ahead and get started. Our first presenter is one who's a veteran to our virtual town halls. He's Stephen Gjerstad. He's a presidential fellow in the Economic Science Institute with the Argyros School of Business and Economics. He has an expertise in organizational economics, and he's back with us today again to give us some of the numbers and facts and figures on COVID-19 cases. So with that, I'm going to turn it over to Stephen to present some of the information on COVID-19 cases.
Thank you, Tom. 9 days ago, I talked about that we appeared at the national level to have passed the peak number of cases, and that's pretty clearly the case now. And we're at a point where I think we can talk about what the path toward reduction of the cases down towards 0 looks like. But I also want to mention a couple of things about just how easily COVID is transmitted from person to person. I'm going to do that with a CDC report on a case study in Chicago. And I also want to talk about the threat that we're going to face with the summer months, which has, I think, been overlooked. So 9 days ago, I showed a chart for Italy and showed them having passed the peak. If we just take a look at this chart, there's a high point about 26 days ago, and it's come down to about, maybe 40% of that level now. And projecting that out, theoretically, this ought to be decreasing exponentially, just as the case increased exponentially. But in practice, it appears to be more linear. And if we project it out, it looks like it's about 28 days from today until cases in Italy are down pretty close to 0. By the time that happens, they'll have about 209,000 cases. Spain is quite similar. They're also decreasing fairly linearly. They had a big bump yesterday, and I don't know what happened there, but in any case, they're actually on a path to be done in about 19 days. So, you know, quite a bit faster than Italy. And there's an interesting consideration there, which is that, you know, I have a friend in Pamplona who's told me that the lockdown there is just very strict. You know, a person can get a pass to go out twice a week to get groceries, and that's it. That's really different from the United States. I mean, we passed the peak, but the unfortunate piece of news here is that 9 days ago, I just used the path in Italy, China, and Spain towards zero cases, and suggested that we would probably follow something similar. At this point, it looks like we're on a path to take from the peak about 94 days to get to zero. That would bring us to about the 8th of July. So we're just really not there. And in fact, then what we're likely to get out of this, if we don't see a bending down of this path, a more rapid reduction of new cases, we're likely to get about 1.8 million cases. Our case fatality rate is about 4.4%. That might be of confirmed cases. And that might be an underestimate of what will actually transpire, because people take some time to get to the point of death if they have a serious case of this. So our caseload, my estimate is that among the cases that could have reached that outcome by now, we're probably at about a 7 to 7.5% mortality rate. So I just want to talk about, you know, what additional problems we have. I noticed this morning that Anthony Fauci said that we could have a second outbreak in the fall. And I don't know what the basis for that is, but you know, maybe they're thinking that this is like the flu, and that the flu is seasonal. It doesn't do well in hot summer months. But Singapore is having an outbreak of COVID right now. They're in the exponential growth phase of an outbreak. And if you look at their weather over the time when that outbreak, when these cases were contagious and being acquired by the people who developed confirmed cases, it's been in the 90s every day. So the summer months aren't going to get rid of the COVID cases like the CDC and the National Institute of Allergies and Infectious Diseases have been suggesting. They might just be a little bit too busy and haven't realized that weather is not going to save us, summer weather. I want to just talk now, just very briefly, about a CDC case. This is an individual who showed up at a meal with some friends the day before a funeral. This was on February 28th. He had this meal with B2 and B21 and B22. Then attended a funeral with these three people. B21 and B22 subsequently had a laboratory confirmed case of COVID, and B21 died 25 days after the diagnosis. The description of what took place at this funeral is they shared a meal, a takeout meal that they had at one of their homes, and then A11 embraced each of these people at the funeral, and then subsequently they got the disease. Then a couple of days later, A11 went to a birthday party hosted by A21, who died about 12 days or 13 days after the party. The similar things went on at the birthday party, a shared meal, you know, kind of buffet style, some people embracing, and of the 9 people, in addition to the host who were at the party, 3 had laboratory confirmed cases of COVID, 2 of them died, and 4 others, excuse me, had suspected cases. So what I think is important about this is, you know, that the summer months aren't going to bring this to an end, and that it will remain easily transmittable. So when people talk about this lockdown coming to an end, or, you know, the cases ending in May. I think we're perhaps overly optimistic on all of these counts. At our current path, we're not going to have our cases all gone until about the middle of July, and the summer months will allow for transmission of this, and it'll be easily communicated. Thank you.
All right, thanks, Stephen. So that's a lot of good information, and we're already getting good questions that we're going to be posing to you, but I think I'm going to hold off on those. I'm going to move on to our next presenter. Our next presenter is Stephanie Saldivar, who was supposed to be with us last time with Michael Burney, but we're really thrilled that she's able to join us this time. She's with the Physician Assistant Program. She's the Director of Clinical Education, and this is part of the Crean College of Health and Behavioral Sciences. She has expertise in emergency medicine, and as a healthcare provider, she's a healthcare provider on the front lines. And I think you're going to get a little bit of glimpse in terms of her expertise working on the front lines of working and treating people with COVID-19 and the medical education area that she works in. And then I will say she has the best, when you see her presenting, she has the best background of all of us. So with that, I'll turn it over to Stephanie.
All right, thank you for having me. I am not currently doing any research, but I can share kind of firsthand what I've been seeing personally in the emergency room that I work in locally. I'm in an emergency room down in South Orange County. And thank you for the compliments on my background. This is my real background, so appreciate that. So I just want to talk a little bit about what patient care looks like in an emergency room right now. So a lot of policies and procedures have changed. They're changing less frequently than they were. There was a period where I would go in for a shift one day, and from one day to the next, the way that we were handling things, the PPE we were wearing was completely different from the day before. We've definitely come into more of a rhythm as we have more information as to how this is spread and how to better contain it, and as we get more data from other areas as well. So first, just some general things that are happening in the hospital right now. Anybody that's coming in receives a clearance. So we're all having our temperature taken before we come in, being asked if we have any symptoms, and we're getting a clearance sticker as well as a surgical mask coming in. All caregivers and staff are only allowed through one entrance to kind of keep track of who's coming in and making sure that nobody is missed. Unfortunately, there's a no visitor policy throughout the hospital right now, of course, to try to mitigate transmission and keep everybody protected. Our labor and delivery floor is still allowing a support person, which I think is wonderful, but everybody else is no visitor policy unless it's a pediatric patient. I know the news has talked a lot about lack of PPE. I am happy to report that at our facility, we have been very well taken care of. Our hospital administration is working very hard to make sure that we are protected. We have a current universal masking policy, so anybody at all in the hospital is wearing at least a surgical mask. All of the caregivers within the emergency department are wearing N95 respirators as well as a full face shield. Testing remains an issue at our facility, as I think it does everywhere. Capacities have certainly increased as far as testing goes, but we are still limited, and we are still really needing to choose who meets the criteria that we've set for testing. Most people that are presenting what we're calling the walking winded, they appear well, their heart rate's within normal limits, they're getting enough oxygen based on their O2 saturation. If we anticipate sending them home and think that they will do well, they're not being tested. One, we're trying to preserve the supplies that we do have, and two, it's not going to change our management of them at that point. So when we were first starting to test, the tests were coming back in about 7 to 8 days. That has luckily improved quite a bit. We're now getting tests within 24 to 36 hours if they're being sent out. And my facility currently has the Abbott rapid testing that's only being performed inpatient. So that's all up on the floor. We don't have access to that in the emergency room. And the issue is, which is a lot, they speak about it a lot in the news as well, there's about a 30% false negative rate. And so any false negative from that Abbott test is still being sent out to a Quest lab or something similar for that 24 to 36 hour confirmation. But most people that are coming in and appear well are being sent home, told to self-quarantine until they are 2 to 3 days without symptoms. Management of suspected and possible COVID-19 patients. We have not quite seen a surge yet, like you're seeing in the news in New York and other highly populated areas. We still anticipate that this may happen, but we luckily have maintained pretty good control of the patient population right now. A few things that have been set up in anticipation of the surge are respiratory tents. So right now we have 2 tents in our emergency room parking lot. One, we're kind of treating like a respiratory waiting room. So anybody that's coming in with a respiratory complaint, in the effort to keep them out of the emergency room and minimize exposure for everybody else, they're being seen in a tent that's being staffed by a PA or an NP as well as an RN. We can do chest x-rays there, the testing if they meet the criteria, as well as lab work if that's needed. But most of those patients are being discharged home, again, with the recommendation to self-quarantine. There is also a tent that's been set up for running codes. So anybody that's in cardiac arrest and is brought into the emergency room from EMS, if they are doing chest compressions or anything that might aerosolize a potential virus particle, we're trying to run codes within a tent, again, to contain that and not spread and aerosolize the virus throughout the emergency room. And so those are things that have been implemented in anticipation of a possible surge. Overall, right now in our emergency room, and I know with speaking with several colleagues in Orange County, the overall volume of patients is actually quite low, but the acuity is higher. So we're seeing fewer patients, but they're much more sick than we're used to seeing. I think there's a couple of reasons. One, I think people that aren't very ill, there may be some fear of coming into a hospital setting or an emergency room out of fear of exposure. We're also seeing fewer sports-related injuries. You know, children aren't playing sports. There aren't as many occupational exposures and workplace injuries since people are by and large at home right now. Number of actual COVID confirmed cases. I've got my next slide will talk about Orange County specifically. I know at my facility, we've maintained a pretty steady number in the low teens for the last couple weeks. But we are seeing patients intubated in their 20s all the way up to their 80s. We're also seeing people discharged home in their 80s. So people at my facility at least have been doing pretty well. They're getting really great care. And I think as long as the numbers maintain or stay manageable and they stay low, that will continue to be the case. I do want to highlight the incredible community response that my facility has seen. From the free meals donated, the pictures drawn by kids thanking us. The other day we had Orange County Fire and Sheriff kind of line the parking lots and thank us on our way out of our shift. So it's been really, really incredible to see the community response and how people come together during a time like this. I do want to point your attention, if you have not been following or were unaware of this website, this is a great place to see daily updates. This information is just from this morning, so they are doing, they're updating it very often. Cumulative cases to date, you can see there, as well as cumulative deaths. Cases reported today were 51 and deaths reported today were 3. Currently hospitalized cases 138 with 68 of those in the ICU. So that's a great way to keep track of what's going on locally. And we'll continue to be prepared for a surge, but hope really that it doesn't come. I just want to kind of highlight how PAs in general, how our profession's responding to the pandemic. For those of you that aren't very familiar with physician assistants or PAs, we are medical professionals trained as generalists. And so the beauty of PAs in a time like this is workforce flexibility. A lot of PAs, especially in highly affected areas, places on the East Coast, are being floated from where they may normally work into labor pools for emergency rooms and inpatient units so that they can help out where there's a need. A lot are staffing tent hospitals that you're seeing pop up in convention centers and places like that in highly affected areas, as well as respiratory clinics and testing centers. And there are thousands also deploying to highly affected areas like New York and New Orleans and Philadelphia to lend their skills there. And also just wanted to highlight another one of our PA faculty that is working in a local urgent care center, also on the front lines. And just highlight that we're honored to be serving the community and do what we were trained to do, and hope that this continues to head in the right direction. So thank you for having me.
Great. All right. Thank you so much, Stephanie, for that interesting work. And thanks for all you're doing in working and treating the patients in the healthcare profession. So with that, I'm going to shift over to some work of Shenyu Ji, that work that she's doing in using data in an interesting way in a partnership with Facebook. Shenyu Ji is a postdoctoral fellow in the Center for Excellence in Earth Systems Modeling in the Schmid College of Science and Technology. And as I said, she's doing some really interesting work with some colleagues in the center where they're partnering with Facebook. And we're starting to hear a lot about this in terms of how we trace and how we use data to be able to solve this challenge, and crowdsourcing of data to look at the vulnerability of communities. So with that, I'm going to turn it over to Shenyu to give her a short presentation.
Okay, good afternoon, everybody. Thanks, Tom, for having me here, and thanks everybody for participating. So my name is Shenyu Jia. I'm working at the Center of Excellence in Earth System Modeling and Observations, Schmid College. Today, I'm going to be sharing on how the social vulnerability and connectivity shape the community risks for COVID-19. A little bit background information on who are we. We study disasters, basically, including the wildfires in California and the impacts on local communities. And currently, we're concentrating on COVID-19. We have a partnership with Facebook, as Tom has just mentioned, that provides us the cross-source products on mobility and connectivity for pre-crisis and in-crisis situations. Anyways, a little bit background.
There you go. Now we can see it.
So there was an interruption here, but no worries. A little bit more information on who we are, and we are interested in the aggregated mobility data and how the disaster response practices can be of great benefit, including the COVID-19 pandemic. So here are the two recent papers our team members have published around this topic. And why we're doing this, because we are studying the risk, and risk is often defined as the exposure by the vulnerability. That's why mapping the differences in vulnerability is a key step towards a better understanding on the resources needed to address the COVID-19 risks. So if there is a particular location that is less vulnerable, however, it does not necessarily mean it will have a lower risk of surge in COVID-19 cases, because the level of connectivity matters a lot. So here is a map of vulnerability, as we just have mentioned before. The way we measure the vulnerability is through a synthetic measurement done by CDC called Social Vulnerability Index. It's a measurement on a community's preparedness towards any kind of disasters or emergencies based on the census data. So from this map, we can see there's a spatial difference between the north and south part of the United States, and the western states may have some other types of patterns, so which we'll get to later. And if we look at the other side of the story, the exposure, so we may find some very interesting patterns here as well. So the way we measure the exposure is through a metric called cross-boundary connectivity. So this is measured by the likelihood of Facebook users being outside of the same county. And the likelihood is calculated based on the Facebook user location history. Right now, I'm showing you a pre-crisis situation. From here, you will see that most regional hubs can be clearly identified by the level of connectivity, as we have seen here. So if we put these two pieces of information together, we end up with the risk map, which is the observed risk, high risk counties we're showing here. So to simplify the map, we're only showing the counties that are more than 10 COVID-19 cases per 10,000 persons by the latest data. And from this map of the county in the United States, let's have a look at the two sides of the story. First, the highly vulnerable and less connected counties, which are colored in bright blue color. So in these communities, their vulnerability is high, but they are generally more isolated from others. So that means the vulnerability may play a greater role in determining their risk towards COVID-19. On the other side, we have a bunch of counties that are highly connected with each other, but they're less vulnerable in terms of social vulnerability index. In these counties, which colored in orange, the connectivity level matters more into determining the level of risk. So we do have a bunch of counties that are high in both levels. So we, for example, ourselves, for example, in LA and Riverside, and they are highly vulnerable. and they are also very well connected with others. So from this map, we do see some spatial patterns, which we'll get to the details later. So here is an example, of 5 states we picked up from the southern part of the United States, where the vulnerability matters more than the connectivity in determining the potential risk of COVID-19 surge. So in these counties, the vulnerability level is generally higher, and they are more isolated from others. And why they still have pretty high risk of COVID-19 surge. So that means in these counties, the vulnerability may have a greater role to play. On the other hand, in the northeast part of the United States and a few states in the Midwest, the connectivity matters more. In this example, these counties are generally lower in social vulnerability, but they are better connected with each other. So in this case, the connectivity kind of filtered the spread and may have a better chance to explain the relatively high risk these counties are facing. So in terms of California, we have a mixture between the two. So you can see that we have a regional difference here in California. The southern part of Southern California, Central Valley, Bay Area, and the northern part of California is a mixture between vulnerability rules and connectivity rules. And so that means a one-size-fits-all solution for California might not be a very good option. So if we look at our neighborhood, our county, we do have a lower social vulnerability. However, our connectivity is high. We're better connected with others. That means in our neighborhood, the connectivity matters to explain our relatively high risk in this map. So several main takeaways from our research with potential societal payoffs in the COVID-19 pandemic. So first, connectivity should really be taken into consideration for future emergency planning and policymaking, because right now they are not very well incorporated with the currently available products. The isolated, more vulnerable communities should not be forgotten, and better cross-county or even cross-state coordination, like Stephanie has mentioned, is really needed to leverage resources available for a particular region. And lastly, we're all in this together. Nobody can be an isolated island out of others. So that means coordinating collaboration is really the key to end this war. Thank you very much for your attention. I'm happy to hear comments and questions. Thank you.
Great. Thank you so much, Shen-Yu, for that interesting work. And our last presenter, we're going to move to the other side. We're going to move to South America for some interesting work that Professor Hillard Kaplan's working on. Hillard is a professor in health economics in the Economic Science Institute within the Argyros School of Business. So we have someone else from the Economic Science Institute with us today. He's also the principal investigator on a really large NIH study that's looking at Alzheimer's disease in 2 tribal populations in lowland Bolivia, which he'll be talking some about today. And some interesting work, because I don't think we hear much of this on the news, about how COVID-19 is moving into South America and how we can adapt some of the CDC standards in some of these isolated populations in South America. So with that, I will hand it over to Dr. Kaplan for his presentation. So you're on.
Thank you very much for having me. I'm going to be talking today about collective isolation for indigenous populations as perhaps their best solution in response to COVID. Right now, there are people in the Amazonia that are dying from COVID, the first people in Venezuela and in Brazil, in Aboriginal tribes, and COVID is reaching many parts of Africa and Indonesia, where there are also tribal and indigenous populations. And indigenous populations tend to face vulnerabilities. They live in areas with very poor healthcare access, poor health infrastructure, and by the time COVID reaches their regions, the hospitals will probably be overrun, and they also suffer from poverty and diseases of poverty. Many have other diseases as well, such as tuberculosis, anemia, malnutrition, that may affect their response to coronavirus infection. But they also do have some sources of resilience. Many tribal communities are involved in their own production of food and can engage in their subsistence. Some do have tribal sovereignty in which they can make rules about who can come into their territories and can exert political controls that in other places they don't have. And they also tend to have a cultural tradition of collective decision making in which they have community meetings and elders and people speak up, and then they come to collective decisions which may help them in responding to COVID. And they also tend to live at lower population densities, which give them the ability to do isolation and to disperse from one another. I'm going to be talking to you about a Bolivian case study in which we're actively involved with two different tribal populations, the Mosetan and the Tsimane. And our basic concept here is that advanced planning and prevention are critical. Fortunately, while cases are spreading rapidly in Bolivia, they haven't reached the regions where these two tribal groups live, and so we have the ability to do the advanced planning and the prevention before we end up facing the disease presence. So one of the groups is the Tsimane. That's a population of about 16,000 people living in over 100 villages that we've been working with for 18 years in our NIH-supported study of aging, and so we have a lot of trust and understanding of this population. They live on their own subsistence. They farm, they hunt, they fish, and they gather. But over the last 5 years, they've become increasingly dependent on selling some of the food that they produce and purchasing in the market. They have high rates of tuberculosis and other respiratory infections, but they do have a tribal council that they use to govern with, and they also have tribal leaders in each of their villages. And they have some limited territorial sovereignty in which they can exclude people from entering and leaving their territory. The second group is the Mosetan, which is a population of about 3,500 people living in 10 villages. They have a similar subsistence to the Tsimane, but they're surrounded by highland people, and they have slightly higher population density, and they're much more involved in the sale of their agricultural products for the market, and so they depend on purchasing meat. And they have they're Spanish speaking rather than the Tsimane that are largely Tsimane speaking, and so they have more access to information. So we're in phase one, the current situation in which COVID is spreading rapidly, but there are no cases in the region. And this gives us the advantage of doing some advanced planning. So we've been coordinating with local, tribal, and government authorities. There is a national Bolivia response to coronavirus, and there's local networks of government entities and health posts that we're collaborating with. I had a conversation with the governor of the province, and so we're joining forces with them, and we're joining forces with local tribal leadership. We've engaged in a process of community level information. So the first step in that was we translated the CDC educational materials into Tsimane. We brought the tribal council leadership and the 10 Tsimane speaking members of our research team into the office and gave them a 3-day education on all the aspects of viral spread, quarantine, differential vulnerabilities to death by age, and the threats to the elders. And then we visited over 50 communities holding meetings to provide information. And then they engaged in these community meetings in a collective decision-making process. It was really interesting to note that they have a history of epidemics from earlier contexts with Western diseases, and they know about pandemics killing many members of their tribe. And so they have a tradition of running away from disease. And so the idea of deciding to isolate and preventing outsiders from entering and to refrain from traveling to town was something that village after village, they came, this is our only solution, knowing that we have at this present time no cure and no vaccine. We've got to make sure that we don't let the disease get to us. And so they signed acts in meetings to confirm their resolutions to do collective isolation. And they also decided to start building quarantine huts and for families to be ready to move into their secondary houses in their fields to move away from other village members. Another
Hill, you want to make sure we have time for questions.
Okay, so let me just move on to what we're going to be trying to do for phase 2, which is that we're going to act as an information clearinghouse for the local tribal population with case reporting back and forth to the authorities, and we're going to use our GIS system, and we're going to be working on rapid testing and contact tracing. And what we're really hoping is to adapt this plan to different communities where they might be able to have markets at the same time. We've written a paper that's generalizing and adapting this protocol to other rural and indigenous populations around the world. And we would like to set up a forum for sharing ideas and sourcing of outside funding. So these, I'm not going to read this list to you, but these are all the elements that we feel that will be necessary in any campaign for dealing with COVID in rural areas where they don't have the health infrastructure, but they do have the strengths. And I can just, I'll stop with a picture of what the community meetings look like. So in the background, there is the poster from the CDC and one of our team members giving an explanation. Down below, we see where they're going to set up posts to restrain people from moving into their village, and then the distribution of supplies. And with that, I thank you all, and sorry for taking too much time.
That's perfect, Hilly, and thank you so much. We've had a lot of great questions being posted, and I really appreciate the presentations from our presenters. I also appreciate watching the Q&A portion of it. Our presenters have actually been real active with actually responding to some of the questions already directly in there. So some of them actually have been answered. We can't possibly answer all your questions, but a lot of them are really great questions. I will say some of the questions where we're kind of looking into a crystal ball are really hard for us to answer. I think I'd rather avoid those right now, but I do want to put some of our presenters on the spot and ask them some of the interesting questions that people have asked. And I'll just do this maybe in rapid fire because we have about 20 minutes now, and I do want to get to as many as possible. I'm going to start with Stephen, and maybe if others want to add to this. You know, a real common question that I've seen in the Q&A and that I think people have, and just looking in the news, some of the latest news reports too, is at least in California, what we've seen, and maybe other parts of the U.S. have been different, but at least in California, some of the projections that were initially made for California were a lot higher than what we have seen come in terms of both number of cases, the number of beds that were going to be needed, number of hospitalizations. Do you want to comment, maybe just, I don't know if it's commenting necessarily on that, or commenting on the ability to predict things like this that have not been predicted before. So it's really challenging in kind of modeling things like this, and why some of these projections have come in lower in places like California.
Yeah. So, you know, one of the things that I thought right from an early stage of this was that the projections were all over the place, and almost everyone was using these things called SIR models. They're susceptible, infected, removed, and removed is either deceased or recovered. And these models are really sensitive to parameterization. So from the beginning, I've avoided those models. They're really great models conceptually, because what happens is as the cases grow and spread, the number of potential new people being infected starts to decrease. And so the models just kind of endogenously take care of the spread and then decay of a disease through a population. But they're really challenging to work with as a predictive device. So I've just kind of taken the model piece by piece, which is the exponential spread portion of the curve, the breaking of the chain that takes place when you have social distancing. That could also take place if you had a vaccine. The vaccines just interrupt the transmission of the virus from one person to the next and decrease what they call R0, the number of people that are infected by each infected person. And then the third piece that I broke out is the decay of the cases, and there isn't really a theoretical underpinning for what I've been doing, but it's been pretty accurate. For example, I predicted 9 days ago that at the end of the day tomorrow we would have 700,000 cases in the United States. Right now we're at about 675, and we're about 25,000 a day. I'll probably end up within a few thousand. And early on in the crisis, when there were 2,914 cases, I sent a message to some of the senior staff at Chapman and predicted that we'd have 70,000 cases on March 25th. We had 68,211 in the US. So just staying away from the theory, I think, has been really helpful in terms of getting better predictions.
Does anyone else want to add to that, or? All right. Shen-Yu, I want to ask, the work you're doing is really, it shows kind of the influence of connectivity, and certainly the regional aspects of that. So I think one of the questions that and it's gotten a lot of attention too with decision makers too. So maybe, but I think sometimes people get very concerned about this too, in terms of the use of data for making decisions like this too. Data privacy becomes a big issue. How people's data that they make available when you're working with groups like Facebook, the privacy issues around that. Whether, you know, the project's called Data for Good, and sometimes people get a little suspicious around that. Can you talk a little bit about how you've worked with decision makers and the issues around data privacy, and if those come up at all in the work that you do with them?
Yeah, thanks, Tom. I have seen a few questions about this issue, and I'm an ordinary person as well, despite the fact that I'm a researcher. I'm an ordinary person who uses this type of social apps all the time, and I do have my own current privacy concern. So I totally understand all these kind of concerns and where you're coming from. So I would like to explain a little bit about how this so-called Facebook Data for Good, and how this is the workflow behind that. I understand people are concerned about the digital privacy. The social connectivity data we are sharing. The connectivity data we're sharing, we're using in this project is an aggregated product, and to be honest, it's aggregated to a county level, which and is only kind of very highly restricted for applied researchers only. It's not open to the public because of the concerns people have. And the researchers who want to use this type of products have to sign a legal document with Facebook, and maybe I think it's kind of similar with other companies offering similar products, to make sure they don't they comply with all the regulations of digital privacy, and we don't have the a permission to share the raw data with anybody, any third-party bodies. And from the policymakers' side, at first they were, to be honest, they were relatively reluctant to make use of that, because they also aware of these concerns from people, and they don't want to just say that, hey, we're going to have a partnership with Facebook and Google to run a project like in South Korea, the government and partnership with a few tech companies to do that. So it's not really happening in the United States, to be honest. So for most of the data right now you see on the internet being shared by the company and being used by the researchers, most of them are like, I'm not going to say 100%, but I think 90% of them are the company's own decision. So they don't really have a very explicit partnership with any kind of government like CDC or FEMA. Maybe they have, but this is out of my knowledge at this point. So to be honest, government is really cautious about that, and they keep saying that we have very strong interest in this type of data, but at the end, what they really want to see is that, hey, since there's a digital privacy concern, we want to know the conclusions and analysis from your end. There's no need for us to see the data. You guys do this analysis and conduct the work, and we evaluate whether these suggestions from you guys can be beneficial for our decision making. This is how this works. The workflow is, first, this is the company of the data provider, and this is us in between running the analysis. And that's the third party, which is the government, would deliver the insights to the government. So this is pretty much the workflow right now.
Great. Thanks. Stephanie, I wanted to ask you, you gave a lot of good insight in terms of working inside the ER, what it looks like, kind of some of the issues. If I had to ask you kind of a question, what would people be most surprised to know about that is being underreported? Because we see a lot in the news about the healthcare workers, the great work that they're doing. Also, what's being underreported in terms of what's going on in the ER and what healthcare workers are having to deal with in these challenging times, also that we don't know and that's being underreported right now.
Sure. So a couple things come to mind. I think, first of all, the good news is it's being more reported now, but the community response that I mentioned has been wonderful, and just the camaraderie of the staff and the caregivers in the hospital has been very encouraging. But something that I think people may not be as aware of is the fact that this is really affecting everybody. It's not just those with comorbidities over 65. We had a healthy patient in their 20s that was admitted and intubated. So just to kind of reiterate that this is a serious illness that needs to be taken seriously by everybody, not just those that are considered to be at high risk.
That's great. Hilly, wanted to ask you, so this is really interesting work and probably not something that we hear at all about in terms of how this is potentially spreading into South America. Can you talk at all, and you showed a good picture of the education that takes place in these remote villages. How has it been difficult to relay the severity of the COVID pandemic to these communities, given the lack of probably the access to worldwide information, the lack of internet, the lack of of information a lot of times to these remote communities. Kind of talk some about kind of those efforts in terms of them learning about this and the fast pace of information that they don't get that we do. You know.
Well, I think that they do have a cultural tradition of epidemics. They've seen them before. They are afraid of them. They're very afraid of Western diseases. So that part of it was not that difficult to get across. What I think was a challenge for us was to take all the scientific information and put it into terms that the native speakers that work for us, most of them haven't even had a high school education. And so, and they are used to translating interviews exactly as we give them to them. And the idea that they had to learn these materials and then put it into their own cultural context and explain it in terms that their own villagers could understand. That was where we had multiple days of back and forth questioning before they were really prepared. And once they were really prepared, they could give a long, we have videos of them giving long explanations and question and answer. And you could see that it wasn't that difficult. I think what's going to be more difficult is for them to change some of their cultural habits around social distancing, because being together and traditional healing is hands-on. And so the germ theory part of and how what you can't see can spread from one person to another, that was more of a challenge. And, you know, fortunately they do have cultural traditions of isolation. For example, when a woman first gives birth, they kind of know that she should be left alone with the baby in her mosquito netting so that nobody gets too close. So those are the kinds of things that we tried to build on to help make this something that they could get their minds around.
Great. We're coming up on 5 minutes. I'm going to give everyone kind of one last final word here. So I think a place where we're at as a community right now is, and what we're hearing a lot about is everyone's getting very anxious. Maybe it's because everyone's sick of being home, but everyone's getting very anxious in terms of, one, when are things going to start reopening? Whether it's the businesses, the workplaces we work at, restaurants, the schools that our kids go to. I guess what I would like all of you to comment on is what guidance, and you all really you all come from great backgrounds. What guidance, if you were sitting in that room with the governor, because I think in many of the way this works is our governors and local decision makers kind of make those decisions. How would you be guiding them, and what advice would you be giving them in making this really critical decision as how we reopen society and do it in a thoughtful way where we don't make the wrong decisions? So I'm going to start with Stephen.
One of the best things is going to be getting a serological test so that people who have antibodies, and in combination a serological test and then a test for the virus, because a person could have antibodies and the virus. So if they have neither the virus, if they have no virus and they have antibodies, they can go safely about their business. And those people will help a lot with kind of reopening interaction among people. But aside from that, we've got a real predicament. The estimates coming out of Denmark from a survey were that about 2% in Aarhus and 3.5% in Copenhagen, which have had pretty high levels of infection, about 2 and 3.5% of the people have antibodies. So we've got a really long way to go. And what I was trying to describe in my presentation is that the summer months aren't going to protect us from the spread of the virus, and the virus is very easily transmitted from person to person. And you know, I think that Anthony Fauci put it really well when he said, we don't decide the timeline, the virus does. I mean, we're really at the mercy of this thing, and we've got to be smart about finding new ways to go about our business without making ourselves vulnerable. And thank
Great.
you.
All right. Stephanie, you're next.
Sure. So I agree with all of that. I think serologic testing will play a large role and should be developed quickly. I also think it's important to keep in mind, and not to instill any fear, but keep in mind that even when restrictions are lifted, the threat is not gone. And so things like practicing hand hygiene and being aware of not touching your face and simple things you can do to stop the spread of any virus will be important to continue doing even when the restrictions are lifted.
Great. Thank you. Shen-Yu.
So I agree with Steve and Stephanie. The number of testing we're having right now is really a really important factor we have to consider in conducting any type of this analysis. Sometimes I'm asking myself, in some places the case per capita number is maybe it's high just because they are doing more testing than others. So this is something I always keep in mind, and I think that should be kept in mind for all the researchers in this situation. And in terms of reopening, I would say connectivity is a very important factor to be considered, since in reopening means the increase in the connectivity, and such kind of steps should be done with precaution and should be considered very carefully. Running some simulations based on that would be ideal if a reopening decision will be made. And at the meantime, like I said, the most vulnerable communities need people. They should not be forgotten. And at the same time, while we're getting prepared for a reopening, at the same time protecting those vulnerable communities would be very important, because they will be the community who will embrace the surge if there's a surge because of the less controlled connectivity.
Great. And Hilly, you get the last word.
Well, I would say two things. The first is that we need much more draconian measures before we can open up. The idea that our governor asks us to politely do things as opposed to legal enforcement of social distancing has been a big mistake, and I think that's related to the slow slope of the curve that Stephen showed us. In the countries like Bolivia, where they know that they have no hope of doing treatment, their only solution is to impose the social distancing. And so you can only shop one day a week between 9 and 12, and that's it. And you go to jail if you break the rules. We're not doing enough of that. And our freedom in our country is acting against our interests. And that if we did that mixed with good science, and I mean science and epidemiology, the testing is only part of the story in understanding who's at risk and where the fires are burning. And we need random testing to do that. And so between better epidemiology and more draconian measures, I think we could make a really big difference. And I think it's a shame that our country is doing so poorly on both of those dimensions.
Great. And so with that, thank you all for participating. Thank you to our panelists for this great conversation. This has been another really interesting conversation about COVID-19. Just a few closing remarks. These presentations that they made, we will be making available on the Chapman Research website. So if you Google Chapman Research, you should be able to get to it. There'll be a link there for Ask the Experts. A recording of the presentation will be there also. The contacts of our presenters will be there. So if you want to have follow up with any of them, you can contact them. And then the last thing I will say, we will continue this because this is a conversation that's worth continuing, and we're going to have another great panel on April 27th to talk about health disparities, talk about the economy, talk about some engineering work that's going on at Chapman, and then we're going to have a historian from Chapman also. So hope you can attend that. And with that, thank you again, and have a great day. Be safe.